afternoon, and thank you for joining today. Speaking on this call today, we have Governor Tim Walz, Minnesota Department of Health Commissioner Jan Malcolm, our State Emergency Management Director Joe Kelly, and the Department of Employment and Economic Development Commissioner Steve Grove. As a reminder to reporters on the call today, we ask that you limit yourselves to one question each, just to ensure we can get through as many questions from as many outlets as possible, and we will allow for a single on-topic follow-up. And with that, I will turn it over to Governor Tim Walz.
Thank you, Teddy. Good afternoon, Minnesotans, and good afternoon, everyone who's on the call today. I appreciate, again, the collaboration to get out as much information as we can to Minnesotans. And sometimes it is a bit overwhelming. I want to take just a moment to talk a little bit about what we did yesterday in terms of an extension of the peacetime emergency. If folks recall, it seems much longer than this, but it was a month ago on March 13th that I signed the executive order that created the peacetime emergency. That's not that, in fact, it's a very common thing that governors do. And in Minnesota, governors do that for everything from flooding to tornadoes to anything that might involve using the National Guard. It opens up certain tools, as we've talked about in the toolbox. If it extends beyond 5 days, the law states that you go to the Executive Council, and the Executive Council is created by all the constitutional offices, myself, the Lieutenant Governor, the Attorney General, the Secretary of State, and the Auditor's Office. And then a vote is taken there, and a majority vote is what it takes. At that point in time, the legislature can, by a majority vote in both houses, the House and the Senate, overturn that. There's nothing in Minnesota statute is very vague that goes beyond the 30 days. So we are interpreting that in the most conservative manner, and it does not state in statute that it needed to be approved by the Executive Council. We did that. Also, though, that sets up the ability of the Senate and the House to overturn that peacetime emergency should they choose to do so. That is the model that we will take going forward. Our hope and our planning is that we do not have to do that very much longer, but should we, and should the legislature not be in session, we would call them back into session so that they would have the capacity to overturn that should they so wish. That is different than the stay-at-home executive order that we extended to May 4th. So some of the confusion around that was the stay-home acts for, except for essential travel, pharmacies, grocery stores, the things we're doing, and folks who are working in those essential businesses, and as we open up more of those. So if there was any confusion, there was not an extension of the stay-at-home order to May 13th. That was the emergency, the peacetime emergency. The peacetime emergency allowed us to enhance veterans' home protection, activated the National Guard to deliver supplies, preserved our personal protective equipment, and allowed some regulatory changes, especially to licensing boards, to make sure that people could continue to use their CDL, could continue to practice in their professions. So those were moves that were taken, and we'll move from there. I just want to make sure we clarified that. I spent this morning speaking to the entire federal delegation. Was on a call this morning. I want to thank the senators and the members of Congress, the House of Representatives, incredibly engaged, incredibly helpful, let us get some insight into where the next potential help will come on COVID-19 and what can be done in the midterm. They also brought up good questions to help us assist together. One of the members got contact information for their constituents should they be one of the folks that maybe are having trouble through navigating one of the state systems, UI or whatever it might be. Another member brought up a very valid point, and Commissioner Malcolm often reminds people of this, the danger of people not going in to see a doctor when they need to because they are concerned even about COVID-19 or they're concerned about using PPE. And I think we need to remind people, if you need to see a doctor, you need to see a doctor. And I think that was a very good point. And they also asked how they can continue to advocate for the things that will make us this transition back to our employment, back to keeping people safe, and the ability to be able to test and trace accordingly. Obviously, today we're watching the legislature here in Minnesota very closely. They're moving a package of things through. I believe as we're speaking now, the Senate is coming back in. But this morning there were some really good things that are moving, especially allowing us to purchase some milk for hunger organizations. Also ensures anyone who's uninsured to be able for Minnesota coverage on COVID-19 testing and office visits up to 100% of federal reimbursement. Legislation clarifies telephone visits, just a lot of things that needed to be cleaned up on this. Legislature and the agencies work together, making sure that they can come back safely and efficiently and move some of these things, and I'm really pleased about that. And then again, proving that we can do many things at one time. The House passed the Alex Smith Insulin Affordability Act. This was a compromise. I think many of you listeners today know that this is something we've been trying to get done for quite some time, years as a matter of fact, and it looks like today that will happen. So I'm certainly grateful for that. I would mention that we are watching the weather closely, not just the storm squalls of here, but the high water marks and the river gauges up in Osseo and Marshall County on Highway 1 up there that's flooded. We've got National Guard up there working. The good news is again, flood stage is 37.5 feet up there. It is now down to 37.68, and at the current rate, we should be able to disengage our National Guard by Friday or Saturday when it gets below 37 and the highway's back open again. So Joe Kelly and his folks over there are running multiple missions at the same time, but the state has the capacity certainly to do that. With that, I'd like to turn it over to Commissioner Malcolm to update the situation.
Thank you, Governor. Good afternoon. I'll start with the global and national update. The global total as of early this morning was more than 1.9 million cases and over 120,000 deaths around the globe. In the United States, we now have over 582,000 confirmed cases, over 196,000 in the state of New York, and over 106,000 in New York City alone. The United States is now reporting 23,649 deaths, 7,349 in New York City alone. Here in Minnesota, we have today a total of 1,695 cases in Minnesota, an increase of 45 from yesterday's report. And as I mentioned yesterday, we had a little bit of data anomaly in the days over the weekend. So today's small total represents some of the difference in timeline, and also the fact that yesterday was a very low volume testing day. But we expect to see those numbers increase further, of course, in the days to come. Sadly, we had 9 more deaths since yesterday's report. So Minnesota's current mortality total is 79. Of these 9 deaths, 6 of them were in Hennepin County, 5 persons in their 80s, 1 in their 90s, and 1 each in Dakota, Ramsey, and Wilkin counties, 1 person in their 60s, 2 in their 70s. As of today, 909 patients have been released from isolation. There are currently 177 patients in the hospital, 75 of those in intensive care. A couple of key points for today. First, an update on grant funding that the legislature made possible a month or so ago in the COVID-19 assistance, specifically to the healthcare sector. The legislature made a total of $200 million available for healthcare, including one initial $50 million fund, which we announced grants for last week. These initial $50 million was for emergency short-term COVID funding needs, which were in anticipation of cash flow and immediate expenses that healthcare facilities were in need of. And today we are announcing the opening of the application process for the remaining $150 million for eligible applicants, which includes health care clinics, pharmacies, acute care and long-term care facilities, hospitals and health systems, and ambulance services. The application information is available on the MDH website. There's no deadline for applying for this funding, but we do anticipate many requests and recommend that folks apply as soon as possible. We're quite sure that there will not be enough funds to meet all the requests that we expect to receive, but we'll work to fund as many as we can based on an evaluation of need of the organizations, but also of the communities and the regions that they're operating in and our evolving statewide and regional priorities. I'd like to also make another mention of something we talked about on a prior call, and that is emergency dental care. In a previous briefing, we had mentioned a concern that some people were going to hospital emergency rooms or urgent care centers to receive emergency dental care, which is not ideal, both because it takes up emergency department resources that need to be focused on other issues, but it also means that the people needing dental care are mixing with those who may have COVID or other diseases. We strongly encourage all dental care providers to make necessary arrangements to provide emergency care for patients. That's entirely appropriate, even during the stay-at-home order. And nothing in that order or the executive order postponing elective surgeries should be seen as conflicting with providing that important emergency dental care. With that, I'd like to turn it over to Director Kelly.
Well, thank you, Commissioner, and good afternoon, everybody. The level of activity to support our COVID-19 mitigation and response continues to hum at a very high level. And I just want to give you a quick glimpse of what's happening in the State Emergency Operations Center today. First, we launched the public-facing dashboard, which we update as soon as any data changes. That dashboard has had more than 825,000 views on the landing page, and the case counters and county dashboards each have had more than 1 million clicks, and that tells me that that's the kind of information that Minnesotans want as we work through this issue. We continue to work with Commissioner Roberts Davis and the Department of Administration to acquire personal protective equipment for first responders. We receive dozens of calls and emails each and every day offering products and services to help with our COVID-19 fight. We just finished another of our twice-weekly calls with all the county, tribal, and city emergency managers from across Minnesota. And right after this call, I'll meet with the commanding general of the Mississippi Valley Division of the Army Corps of Engineers to discuss the support that his organization has provided to us as we finish up our work on the alternate care site planning effort. And those are just a few of the highlights of what's going on here each and every day. Even though many of us just celebrated Passover and Easter, and Ramadan begins in a little more than a week, we know that the virus does not take a holiday, and neither will Minnesota's Emergency Operations Center. The second day of Severe Weather Awareness Week focuses on thunderstorms, hail, and lightning, so please visit our website for more information about how to protect yourself and your loved ones from those summer weather hazards. Next is Commissioner Steve Grove with DEED. Commissioner?
Well, thank you, Director Kelly. Good afternoon, everyone. We continue to update the state on the numbers of unemployed Minnesotans who are applying for unemployment insurance, and we have a new milestone to announce today. It's not a good milestone, but wanted to let folks know that we are now up to double the number of applications that we received in all of 2019 in the last month that we've been accepting applications during this COVID-19 crisis. So in 2019, we had 219,625 active accounts for unemployment insurance. And as of yesterday, we're now up to 451,790 applications in Minnesota. So the scope and scale of this is stunning. Of course, those aren't just numbers. Those are real people who are either completely out of work or working much less than they did before. They have families to take care of and bills to pay and rent or mortgages to pay. And so we know this is a really difficult time for people, and it's why our UI team is just working around the clock to get those benefits out to deserving Minnesotans, and that includes an extra $600 per week top-off payment that came through the federal government. And I think it's important to continue to look at sort of who's most affected here and to get a glimpse into the demographics. So I wanted to share that we are now up to about 14% of Minnesota's labor force that has applied for unemployment insurance. Again, that's not an unemployment statistic. It's just the percentage of the labor force that's temporarily out of work and is applying for benefits. We see about 15% of the applicants overall are under the age of 25. 21% are over the age of 55. Right now, we see that about 24.5% of those who've applied have a high school diploma or less. That's the highest percentage as it relates to educational attainment. And we continue to track the gender breakdown of unemployment insurance. We're at about 45% of the current application pool is men, 55% women. So this has affected more women as of today than it has men. And I think some of the more startling disparities, of course, come down to race. Overall, about 75% of UI applications are white, which is about 12.2% of all whites in Minnesota's labor force have applied. But for people of color, the numbers are much higher. About 25.8% of people of color in Minnesota's labor force have applied for unemployment insurance. So we're aware of that, and it's something the administration is tracking closely as we move to get those benefits out as quickly as we possibly can. I want to provide some clarity around pandemic unemployment insurance, which we've talked about a couple of times on this call. This is a federal program that came out of that CARES Act in late March that kind of builds on an existing program called the Disaster Unemployment Insurance Program, which was designed to help in very acute disaster situations, you know, a flood or a tornado or something that strikes a particular geography of the country. What the federal government has done is they've expanded that program to include really the entire country through pandemic unemployment assistance. And the core idea here is to get unemployment insurance dollars to people who are not usually covered by the program. So most pressingly, this is self-employed individuals or independent contractors. Just to put into context, that program it's essentially standing up an entirely new government program because unemployment insurance works through a set of eligibility rules, administrative guidance that the federal government gives us that is meant, of course, first and foremost, to get people who deserve their money and prevent fraud from those who would seek to cheat the system and pull money from our trust fund when they don't deserve it. And so that becomes the challenge in standing up a new version of this program for self-employed individuals for whom deserve this money, who need to get this money quickly, but for whom we want to make sure that we are able to administer the program effectively and efficiently and maximize our trust fund and the efficiency of it. So no state in the country has yet moved publicly to begin paying out money to unemployed, self-employed individuals, but we're moving very quickly, and I think quicker than most states. We are working very closely with the Department of Revenue to build out an automated process to speed up income verification. The team's working around the clock on building a new technology platform and data sharing agreements to ensure that we can get this money out quickly while also protecting ourselves against fraud. And unlike most states, we're actually encouraging and asking that people who are self-employed do apply now. You'll get denied based on the current rules, but by having you in our system, we'll be able to more quickly get you that benefit as soon as the platform is up and running. And so we ask anybody who is self-employed or an independent contractor to apply right away and get yourself into the system, and then we will proactively reach out to you once the system is up and running. We're expecting it will be operational by the end of April. So I want to give an update on that program. We get a lot of good questions about this and want to make sure that Minnesotans understand exactly the work that's going into this and why it's important and why we're moving as quickly as we can to get this right in a way that will help more Minnesotans get help when they need it. And I should just offer as a final point on that, anyone who is eligible for these benefits will get paid backdated to the moment the CARES Act took effect. So rest assured that you will get the money you deserve when we're up and running. I also wanted to share just a quick note on our planning process for how we're working with business and labor leaders to safely reopen businesses when it becomes safe to do so. As the governor said in his executive order last week, the key message right now is to stay at home. But of course, at some point, we won't be staying at home, and people will be going back to work in a new environment. And so in an effort to make sure we're planning for that moment, the governor has asked DEED, the agency that I lead, DOLI, which is the Department of Labor, and the Department of Health, to start coordinating with the business community and with labor leaders to adopt the right principles and protocols we would need to make sure that reentry into our economy is done safely. And so we're talking to lots of different labor and business leaders on this through a lot of different venues. We also have a public forum that is up on mn.gov/deed/critical, and we received hundreds of submissions and ideas from business leaders there already. We continue to read every single one and categorize them so that we're learning day by day from businesses who are trying different things to engage in social distancing on site that will keep workers healthy. So in the short term, the question really is, could we begin to have some workers go back to work and practice the same social distancing guidelines we've asked society to follow more broadly? And our team is just working very methodically to get a recommendation to the governor about what businesses could safely begin reopening. But above all, these decisions are going to be based on facts and science. And the last thing we want to do is extend this pandemic any longer than necessary by opening up some things too quickly and putting more people at risk. So that's the process we're engaging in, doing the right planning to give the right visibility into the situation and learn from experts about how we can open up our economy when it is safe to do so. Lastly, just wanted to continue to celebrate and acknowledge the businesses in our state who are really doing so much to improve life for people in their communities. One of our, of course, most beloved businesses in Minnesota is Hormel Foods. They have a great Spam museum that I think is known the world over as a fun destination to visit when you're in Minnesota. That museum, of course, is closed right now due to the pandemic, but the employees there have really rallied together to work with 12 different local restaurants in Austin to deliver meals on a daily basis to 300 different food insecure seniors in the area. And of course, Hormel is being generous and paying for those meals, which helps local restaurants and of course helps those in need as well. So we're grateful to Hormel for being a real leader there in Austin to help those in need with food and help those restaurants find new revenue streams at a time when that's so difficult. With that, I'm going to turn it back over to the governor.
Well, thank you, Commissioners. Thank you, Commissioner Grove. I think that's a good segue. I also spent this morning talking with ag leaders about the challenges that were certainly already there from our commodity groups that are facing unprecedented hardships ahead of time in commodity prices. Now, some of the lack of markets. Also spoke with United Food and Commercial Workers who represent about 1,700 food processors at the JBS plant down in Worthington. And of course, they're watching very closely the Smithfield situation. I know Bill asked about that yesterday, and I think that story has been a top story across the country because of the concerns that have happened there and then it shut down one of the nation's leading pork producers in Sioux Falls. And so we're working, and it segues with what Commissioner Grove is talking about, ways that we can look at that line down there in terms of social distancing to keep it going. These folks want to continue to work, but they have many of the same concerns that others that are on the front line can't social distance the way they need to, the PPE that they're needed, whether it's face mask, gloves, and those types of things. But I think there's ways that work, and we keep talking about it. We need to keep not only these places up, we need to get others from lessons learned. And I think there's reasons that there's some positive signs that are out there. I do think and appreciate the administration's work and Secretary Mnuchin. I think many of your listeners today, the stimulus checks arrived for people who had direct deposit, and as Commissioner Grove said, the state of Minnesota moved the $600 to take some of the immediate pressure off. But as we talked about yesterday, and as we're planning all of the things that we asked for during our just 16 days now of stay-at-home order to get the hospitals ready, it was to get ready to stand back up again on what things would look like, how we would get our testing. We're moving full speed ahead on expanding testing to an unprecedented level. And then I'm like everybody else. I'm following the developments that we see come out daily. We get to reevaluate where we're at. We get to change projections based on what the real world is showing us. I follow every time I see one of the studies that's out there. I read one yesterday that it said COVID-19 could carry 13 feet, which certainly puts it beyond our 6-foot social distancing, and also said could be carried on shoes. Now, one of the things is we have to validate these studies. They have to be peer-reviewed. There's a sense of urgency, but you need to get it right. Or the story that's coming out of Reykjavik, Iceland, that Iceland is going to test all of their citizens. Now, obviously, that's about 360,000, about the size of St. Paul. But the reason that it's interesting there is they're showing that 50% of their people who are testing positive had no symptoms at all. Now, that is a double-edged sword in that is very good for those people, that especially if they have immunity, they got it, they didn't get sick. It can be very bad if they're walking around and they can they can spread to others. And so these are lessons learned that we have to adapt in real time, because basically since March 13th and the full court press on this, that's the time that we have. But I can tell you that we're thinking and looking and evaluating, putting in that data, listening to it, both on the health side and on the economic side. Restaurants are going to look different, certainly initially. If we're able to get them open, they will certainly have fewer tables. Maybe the outdoor patios are the way to go now that we're getting in. Well, hopefully by next week we'll be getting into spring. Those are the things that we're working on right now. Those are the things that I'm asking, not just these commissioners, but as Commissioner Grove said, working very closely and in tight communication with both healthcare providers and the business community. And with that, we'll be glad to take some questions.
Thank you. As a reminder, to ask a question, you will need to press star 1 on your telephone keypad. Your first question comes from the line of Elmi Havoc from Care 11. Your line's open.
Hi, Governor. Thanks for talking with us today. Going back to the idea of ramping up testing right now, you said you're full speed ahead on that. And I know yesterday you mentioned a couple examples of what that might look like, even making our own swabs here, looking at what's going on with the reagents. Can you give us some more detail on what your team is doing more specifically to ramp up that testing right now?
Governor, did you by chance go on mute?
Oh, I'm sorry, Emily. Thank you, Teddy, for that.
No problem. Thanks.
I try. You'd think I've done this enough, I would get that. But yes, and I spent last night, and I'm going to have Jan do some of the operational sides of this, but from the strategic side, we talked to all of the major healthcare providers, cover about 90% of the state, and then I spoke extensively last night to Dr. Faruja down at the Mayo Clinic, and we're talking about how do we make this, this broad-scale testing that really hasn't been done in the country to this level until we saw it in New York City after they were burning hot, and talking about where are the shortages, how can we use the existing ones we have, how do we stand up and create our own. And I think there's the belief that we're not overly optimistic at this point that we can overcome all of the reagent sides of things, but we are pretty optimistic that we can significantly ramp up in the very short run, which will start to give us a lot better picture of where we're at. So, Jan, I don't know if you'd like to speak about this, but I know I'm setting very lofty goals for my team and getting feedback almost hourly from places like Mayo on what's possible. But, Jan, if you could update a little bit after our conversation last night with Dr. Faruja.
Sure, Governor. Well, as the governor indicated, there's just a lot of good collaborative conversation going on with the health systems, several of whom have been trying to develop their own tests. Some of the tests intentionally are trying to use different methods and different types of reagents to avoid competing with the ones that have been problematic globally. So as more of our providers come online with validated tests, that just increases the capacity for the diagnostic tests that we're doing today to indicate whether someone currently has COVID-19. So we're simultaneously ramping that up and trying to figure out ways to best coordinate so we can get the highest priority test samples processed very quickly for anyone who's in the hospital, anyone who's in long-term care, et cetera. So not only ramping up the capacity, but making sure that we get fast turnaround time as much as possible. But in addition to just growing the volume of the kind of tests we've been doing that require laboratory confirmation, also in the works are the development of point-of-care testing that could be done, on the spot in a healthcare provider system or perhaps a drugstore. And then there are a number of different types of serologic testing that the governor has talked about before, more than one type of test and more than one purpose for the test. So I think, as I think we mentioned yesterday, I think we're developing a more robust strategy that's ramps up testing by smartly using the different types of tests in different circumstances so that we can really spread that capacity and increase that resource. There's a team of folks folks who are expert in laboratory operations, as well as physicians and public health leaders that are working as we speak to kind of flesh out that general strategy of let's ramp up in all of the relevant areas, all the relevant type of tests. So they're starting to quantify that and set some timeline goals that we'll be able to share with you soon.
Thanks, Commissioner, and thanks, Governor. Just a follow-up here, if any of our ramping up involves actually producing more of any of these materials in Minnesota, is there a concern that those could be co-opted by the federal government as we're trying to increase the capacity in Minnesota?
Well, that's a great point. I certainly hope not. We certainly want to help our neighbors all we can, but I've just gotten to the point if it's the swabs that's holding us back, and I think many of your listeners now understand that this is one of the barriers to reopening and getting back to a sense of normalcy, then we should be able to make them here. We have massive manufacturing capacity. We have incredible innovation. I would hope that's not the case because some of that has happened. What I would like to see is, I think, and this is what you're seeing other states do. As I've talked to other governors, we may have a consortium of more states wanting to be a part of this. I think that's what others would start to do too. And it appears like that's the model we're taking now, is kind of a loose Articles of Confederation type of approach with some of the states gathering together, but I would certainly hope not. And I would. This is a great question. If we do this, and what we do is we build resiliency into this, I think, the way the epidemiology goes on this is that we'll get through this. And the good news is it doesn't appear to be burning as hard. It doesn't appear to be killing as many people, which is good. And that's a testament to the good care they're getting. It's a testament to the social distancing. But when it comes back again, which it will until we get a vaccine, if we have this testing regimen in place and we have that depth of being able to do it ourselves, it will not be as disruptive or nearly as disruptive next time, because we will just simply test, isolate, and keep those people out while the rest of us continue to go about our business. So this is why this is so important. It's why I keep stressing it's not just in the short term. It's for the duration of this until we get a vaccine. So it makes good sense now to build on the front end. So thank you.
Thanks very much.
Your next question comes from the line of Ricardo Lopez from Minnesota Reformer. Your line is open.
Hi there. I wanted to revisit a little bit about the Sioux Falls, Smithfield food situation. Wanted to know, for instance, if a similar outbreak were to be seen in any of the packing plants here in Minnesota, like Worthington or Austin, of that size, an outbreak about that size, would the current healthcare capacity would the healthcare capacity be available to treat a surge of patients like that? And how would Minnesota work to avoid further disruption to the food supply? I think Smithfield is warning about sort of the perilous state of the country's meat supply.
Yeah, I'm going to have Commissioner Malcolm speak to the bed space and everything, give her a minute to pull up the numbers in and around Nobles County and, of course, the surrounding area. Ricardo, I do worry about this, and I think everyone listening, this is really a concern. And I don't think there's an arrogance to believe that if we're doing something different here that we can avoid that, because South Dakota took a different approach. I don't think the virus necessarily cares about that. And I think the cross-border traffic that we see with our bordering states is so great. That's one of my concerns, that I think we need to build broader coalitions that ignore those fake lines on the ground and recognize that people move back and forth in a pretty determined pattern. So we do have things that I believe are in place. We're putting an effort on this. I think both JBS and Hormel are taking the precautions, but there is a definite concern that this could happen. It's just the nature of if any listeners have been through there, these are very efficient facilities, but they're also tend to be pretty crowded. They're pretty labor intensive. So we do worry about that. Jan, do you want to talk about, the regional ability and why we're thinking that should we need to move ventilators or set up those beds, what's been set up in and around the area with alternative care?
Yep. I think at this point in time, we're in good shape capacity-wise in the southwest part of the state. And as the governor has mentioned, we have fairly real-time capacity data in terms of the hospital beds available, specific ICU beds, and ventilators. So the goal, of course, is to keep people as close to home as possible and as close to healthcare facilities as possible. So the first priority of expanding capacity is for hospitals to convert some of their non-critical care beds into critical care, and they've all got plans for how they would do that, how many beds they could convert within a 24-hour period, and an additional amount of beds in a 72-hour period. And then only when we've tapped out the capacity of hospitals to expand within their current footprint, which is way preferable in terms of using that infrastructure and the protective environment that creates for patients, we would consider and have plans in place to stand up these alternative care sites that would really be ways to offload, if you will, more of the hospital's regular non-critical care capacity to these community care sites so that more of the beds could be converted to critical care. So that's kind of the third level of planning, if you will. But the National Guard has been assisting us and the Army Corps of Engineers in evaluating potential sites in each region of the state for those alternative care facilities. So that's one of the things we've been doing with this planning time is the hospitals have been identifying specifically how they would convert capacity to critical care, and the Southwest region's in good shape there, as well as these alternative care sites. So as we're sitting today, we're certainly able to handle the volume of cases that have been increasing at a steady pace, and could handle, at least regionally, if not completely locally, a surge that would come from a major exposure in a plant such as you mentioned.
Gotcha. Thank you.
Your next question comes from the line of Tim Nelson from NPR News. Your line is open.
Hi, I want to return to the serology testing a little bit. I'm sort of curious, Governor, you've talked a lot about a Minnesota moonshot and widespread testing and that sort of being the dial that you use to adjust the restrictions in Minnesota. But I'm curious about how this is going to work, if the state is going to track people or, as Representative Drazkowski said on the floor today, people are getting weary of this. Is there a danger that once the testing starts, everybody's just going to say they were tested and go back to work? How is this going to function going forward?
Sure, people are weary. I don't deny that at all. I think all of us long for the day where this doesn't have to happen. That's why we are pressing to get it right the first time. And again, I caution, and Commissioner Malcolm cautions me to think about this. This research is very early. The FDA has provided emergency authorization for some of the serology tests. We don't know for certain how long you're immune to it or who is. But I think our view is the way we want to see it, and we think we have the capacity to do this, is especially those on the front line, hospitals, long-term care, people that are interacting with the most vulnerable folks, that we are testing them serology-wise to know potentially if they've had it or if they do have some immunity to it. Then those point-of-care tests, which, again, I would love to be able to deploy these to, Hormel, to test all their employees if need be to make sure that doesn't happen. And then just the steady ramping up. Instead of doing several hundred or 1,000 a day, we start building that capacity of 5,000 so we start to know. I would love to go out and test an entire county in western Minnesota and to be able to know. And I think that's the strategy that states and countries that have managed this have done. We simply did not have the capacity in the beginning, but that's no excuse not to get it now. So I'm trying to turn over every stone. We have got immense capacity on medical manufacturing in Minnesota that is, almost unprecedented, and those folks are being incredibly helpful. So it's my goal that we continue to build on this. We simultaneously figure out smart distancing, just like we did. And we said, you know what, these landscapers aren't in contact with one another. They're proving they can disinfect their equipment. Let's get them back out there. Let's get some of these folks going. If we have manufacturing plants that can show us that they can do that distancing, as we're simultaneously ramping up the testing, that will let us move, I think, very quickly. But we're going to need this, and I just remind everyone, we're going to need this testing because this is not going to be the last time this thing happens. Now, certainly there will hopefully be some herd immunity, but the herd immunity aspect that people say, let's just let us all get it because a lot aren't going to get sick, is incredibly dangerous to the large number who are vulnerable, and we don't know how long it's going to last. So I'm telling you the best that I can on this. We are reinventing things, if you will. We're going back to the playbook on pandemics, test, trace, isolate, and we're doing it while we're moving society back into a more functional. And I do want to remind folks, it's not going to immediately look like it did before, but if we can get to a place where, we're able to open as much as possible, we're able to maintain the social distancing we're doing, because I get it. I wish we could stop this today. I wish I could say, you know what, it's magically over. We can all go back to work. We can all go down to the restaurant or whatever, but that will kill people. And it will, in the long run, hurt our economy at the same time, because keeping Smithfield open did not keep Smithfield open. Now it's closed because the workers are sick who they need to do the work. So we're pushing it, and I want, and telling my folks, I think these expectations are pushing the limit very hard. I'm asking for them to try and get this done in days and weeks, not months, because people are getting frustrated. And I said this from the very beginning. There is a limit to everyone's patience. And in this case, running out of patience might not just endanger you, it might endanger your neighbor or someone else.
Just to follow up quick, do you anticipate that any of those 70 serology tests that the FDA has given preliminary approval for can be replicated here in Minnesota in any reasonable amount of time?
I do. I'm counting on our expertise. I don't think it's Minnesota exceptionalism. I think it's proved out. We have many of them, Mayo being just one of them, University of Minnesota. I do think so. And I think that Minnesota is going to lean into that and be the example for it. This is not we're not a experimental drug trial, if you will, but we are willing to try this, track, test, and do the necessary work. Now, it's labor intensive, don't get me wrong, especially the tracing, the contract tracing. Minnesota Department of Health does this as well as anyone, but we're getting overwhelmed now when we're in the thousands of cases, because the exponential growth, one person infecting 4 nearly. Now we're up to 8,000, and those people infecting 4. So it becomes quite a bit of work, but here's the thing. We need to do it. We need to do it to get back to normal, and we need to do it with a sense of urgency, because everyone out there, me included, I am sick of this, and I want us to get done as quickly and as smartly as we possibly can. And I think, again, as I said, we're well positioned because of that massive health infrastructure that's already here.
Governor, if I could just jump in for a second on the question, and because you referenced the large number of types of tests that the FDA is approving, there still needs to be real care taken to assess the accuracy and the validity of each of them. And our understanding is that there's a pretty wide range in reliability in these tests. So we just are going to want to caution Minnesotans to there's going to be a lot of stuff on the market, and we're going to want to apply some really good science and careful validation to make sure that we're using things that actually have as high a rate of reliability as we can get. So thanks for the added moment there.
Thank you.
Your next question comes to the line of Kent Herdahl from AARE TV.
Thanks, Governor. This is for you and possibly Jan as well. When you talk about this testing moonshot and expanding things, how much of this is really going to be borne by providers themselves as far as the state's own limitations when it comes to testing? And how do you balance that with some of the concerns expressed recently by MDH when it comes to providers not necessarily testing everyone they should even right now?
Yeah, boy, this is the question, and in this space we're in, there's a lot of raw conversations that have to happen. There has to be a lot of honesty amongst providers, and this is one that we are trying to balance. You're right. It's the private capacity to do it. The state labs were never designed to do all of that. We can help provide resources and some of the guidance, and I think what we're seeing is Minnesota's healthcare system is more cohesive than most states. In most other states, the governors have simply just said it and ordered it that, this is going to be the provider and this goes. The conversations we're having with folks is asking how can we get this? So, Jen, I would segue to you and trust your intuitions on this, because these are touchy discussions, but they need to happen, and the public needs to understand why it becomes a little bit tricky to ask these health providers to do kind of a coordinated moonshot, state-aligned testing regimen.
Oh, absolutely, Governor, and you're right, and it just goes to again show the interconnectedness of all these pieces. It's not just the laboratory capacity on the back end, it's the capacity to collect the samples on the front end that not only requires swabs, but it requires healthcare providers using PPE, which we know is in critically short supply. So there's all kinds of legitimate reasons why the providers have said, well, we'd love to test more people, but we really need to, test only the highest priority people in order to conserve PPE, for example. So that goes again just to the importance of developing multiple kinds of tests that aren't all dependent on the same types of processes or the same types of providers to be able to do. So I think it's a perfectly great question. I wish there was a simpler answer, but I think it's working together, as the governor has said, and I think the healthcare systems know that the state is here to partner with them and try to support them, and not just expect them to work miracles, but to partner with them to try to work on improving the supply chain and doing what we can do to support their capacity to deliver, because we very much appreciate and realize that they're the ones, they're really the point of, the point of where the care meets the patients. And that's our job, is to support them to do that.
Just following up real quick, can you talk a little bit more about some of the concerns you've had raised in terms of people getting the tests that they need? I know that's been kind of directed at the providers pretty pointedly a couple of times in the last week. Can you speak at all to, is this a widespread problem amongst providers? Are there just a couple that are kind of pushing back right now?
Well, some of it is, and we've needed to take a look at, has the guidance been clear? Has it been specific enough? Are we getting it out through all the right channels? So working closely with the hospital association and with those regional coalitions to make sure that all the providers are getting the message of what are the priority populations to test. And some of them, just will say they don't have the capacity to test in that site. So another thing we're trying to figure out how to build. Some other states have done this, frankly, better than we have so far. How do we build information resources for consumers so that they know where they can get a test if the place they went isn't testing, doesn't have the supplies or whatever? Where's the next closest place? So we've certainly got some work to do, not only to make sure that all the providers have the message, and to the extent they have the capacity to deliver, that's first prize for everybody to be able to do that. But if not, we've got to help people find places they can get the tests when they clearly need them.
Thank you.
Kent, thank you, Kent, for your questions. You're absolutely right. And it's our job as we're building up this PPE. And if you look on our website, you start to see that supplies are starting to get there, and Commissioner Roberts-Davis and her team are doing a great job. But I get texts to me, or I see things that come through my family or friends that folks are saying, hey, I'm a leukemia survivor from 20 years ago. I'm a little nervous about this. They're telling me I can't get tested. And should my family be separated from me, or how do we do that? There's a lot of questions that could be answered with testing. And I can't imagine Minnesotans out there right now that are concerned about this. They're worried about someone in their family, and we can't provide the testing. We've got to figure that out. And we thought in the first week or two, we were told that there would be this massive uptick. There would be millions of tests given. That has not materialized at this point in time. And it makes sense to me to prioritize ventilators, to prioritize PPE to the hot spots of where they're at. But if we don't, and we prioritize all the testing away from places that are not yet experiencing the high numbers, we're just going to have to repeat it all over again. So I'm making the case, and so are other governors, that if you're putting PPE in the ventilators and the triage to the already existing hotspots, start diverting the testing to the places that aren't yet hotspots, and we can prevent it. And I've not yet seen them on a federal level or a concerted effort to maybe think that way. So we're going to just do it ourselves, and we'll see. You know, it's obviously not the best because the resources of the federal government are greater and could bring to bear to it. But I do still think Minnesota may be as positioned as any state for a lot of reasons. Not least of which is Minnesotans are still continuing to keep our rate the lowest in the country by, again, maybe very frustrated, maybe very just tired of this in social distancing, but they're doing it.
Your next question comes on the line of Kate Radatz from WCCL-TV.
Thank you, Governor. Following up on the testing as well, when you look at the need for expanded testing and contact tracing, are you able to say how you think that need will fall in line with the expiration of this stay-at-home order? In other words, are we looking at beginning to possibly reopen the state with the projection of testing and contact tracing, or will we not be ready?
Yeah, it's and I just have to be very candid. I like the idea of us going shorter at these 2-week periods. In the first one, I said I wanted to see us get our feet under us in a very aggressive way, to have the beds, the ICU, the ventilators, and then be able to constantly update modeling around both the health and the economic impacts of this, so that we could then readjust our plan. I think we did a pretty good job of that. I think we're as Jan said, we're not going to rest on our laurels, but we could withstand a pretty heavy hit, and people would get the care that they need. Now, this second one, we're really continuing to focus on this testing, and I'm driving that. We can't wait a month, and I would argue we can't wait 2 weeks to figure out how to get this in the pipeline, to get this testing going. I want to see our daily tests start ramping up towards that 5,000 on the front end test, and then I want to see them working in. And again, as Jan said, to be very cautious, but I think we need to try and move into the serology test to see who's had it and if there's some immunity. And so, yes, I'm tagging that to the idea that I think that if we do this right, we can start to see changes. I am very much of the belief, and wrote it into that stay-at-home order, that we need to simultaneously figure out how to open up the economy and protect our people. We've always believed that, and we believe they went hand in hand. So I'm tying a lot of this onto the testing, because every major public health advocacy group, every major hospital is taking it that this is going to be critical to that. So yeah, I'm tying it to that. And yes, I think we would love to see. Now again, the virus will dictate again what it's going to do, but we don't have to be. It does not have to control us. We are controlling this virus to a certain degree in our stay-at-home orders. We're controlling its death rate by having the necessary material for our hospitals. And I think if we get the testing, we even start to control it a little more. If it gets to people who are compromised or are older, they're in a pretty bad situation. If we can get them to the hospital with a ventilator, we can do an awful lot of good. But this testing will ensure we start to separate those groups out. So in answer to your question is that my hope is that we start to see significant improvements and significant testing data by that May 4th date. And then that will help inform us, along with numerous other touchstones that we're looking at, to what we can do and what we can change. So from the first stay-at-home order to the second stay-at-home order, there were changes made in that, incremental changes. My hope is we're able to see that and start to accelerate it.
Thank you. Just a quick follow-up. You talked about the need for contact tracing. As far as expanding that, would that include hiring? I know there's a team that's helping with this contact tracing with MDH, so possibly a question for the commissioner, but just what would that look like to expand that?
Yeah, I'm going to let Jan answer that. One of the things that we've done very early on, and this is a testament to the commissioners and to Myron Franz, is the ability to be able to reassign people. Now, I know that this is a specialty work. This is tough, hard, grinded out work, but our hope would be is that it does take a lot of people, that we would hopefully be able to get folks moved over there. So, Jan?
Absolutely, Governor. That's right. We imagine having to really ramp up training to help more people learn how to do this. We've got lots and lots of colleagues at the School of Public Health and at other places of higher education. Lots of health professionals, and our colleagues in local public health are a ready workforce as well, who do a lot of this work on other diseases. So I think we've got a certain amount of the workforce that's ready to go. They just need to be, kind of trained up on COVID-specific things, and we've got a need for developing some training to expand the workforce beyond kind of the current already public health resources. We also know that the Centers for Disease Control and Prevention is trying to ramp up nationally to be able to deploy some additional Public Health Service Corps folks around the country where needed. So whether that will apply here or not, too early to say, but I think we need to really be creative in our thinking about who can help us. And there might also be some technological enhancements to our ability to supplement the kind of the traditional shoe leather epidemiology with some other ways of applying our surveillance data and other things to assist with this.
Thank you.
Your next question comes from the line of Jeremy Olson from Star Tribune.
Yes, hi. Perhaps a question for the commissioner, but now that we have 79 deaths, I'm just wondering if you can talk about the epidemiology, what you're learning about the people who died, what they have in common, what they had unique, and if we're getting any lessons learned from those about how we can prevent future deaths or prevent those kinds of things from happening.
Thanks, Jeremy. And if Chris EHRESMANN is still on the phone, I'll invite her to chime in on this point. But it's another area that's really ripe for research and for partnering with some of our healthcare community and healthcare researchers who are poised to start helping to look exactly at that. What do we know about the specific comorbidities that mean that the disease progresses in slightly different ways for people with specific conditions? So that we think is promising for future research. But Chris, are you on?
Yep, I am. We are actually doing an in-depth evaluation of our deaths. So we're doing a review of all the deaths that have been identified, just as we were doing for hospitalizations, and so that is underway. I can tell you at this point that, the things that we've seen just with some of our, rough epidemiology is that like 57 of the 79 cases have been in individuals associated with long-term care. We've continued to say that is, a focus of our efforts, reaching out, and obviously continues to be as we look at our deaths. The other thing that we're looking at related to our deaths is presence of underlying health conditions. And so we're seeing that the cases who died, 98.5% have pre-existing or underlying health conditions. And we're also seeing that in terms of the age range for our deaths, the range is 56 to 100, but the median age is 87. So we're seeing our deaths in individuals who are older with underlying health conditions who are in congregate care settings. And that is where we're putting our energies in terms of trying to be proactive in reaching out to these facilities, offering assistance, and, providing training and guidance.
Thank you.
Operator, we have time for one more question today.
Thank you. We now have your final question from Dave Ulrich from Pioneer Press.
Thank you. This is a question for Jan or Chris. First off, a quickie. How many people have been put on ventilators, and how many have survived?
Chris, I don't know if you have that level of detail about the vents. I do not.
I don't. I actually had a portion data from, I believe, our hospitalized cases, and I'm going to see if I can pull that up, because I did have that at one point. It was like, I want to say 20%, but Dave, let me get back to you with that data. It's not complete for all of our hospitalizations, but for the portion that we did have, we do have information on whether or not they're receiving oxygen, if they're on a ventilator, those types of details. So I'll pull that up.
Okay, thank you. And just to follow on the previous point about the median age of death and everything, we have run stories, and the other media has, on people who have died, and their families have been told by the doctors, that they died of coronavirus-related diseases, but they're not included in the death count. And I think that may be because they didn't necessarily have a positive test. But I'm just a little bit confused about how we're tracking deaths, because we have people that are under the age of 56 or whatever it is.
Yes, and I think the commissioner has talked about this on previous calls, and I'll try to provide additional information. But right now, yes, the 79 cases that we are referring to right now are individuals who were tested for COVID and have died. So it's someone who has a positive test and has died. And there is a process that our Vital Records Department uses, and will be reviewing death certificates to see if they have, COVID listed on the death certificate. But that process takes a bit, and so at this point we are providing information on the cases who have had laboratory confirmed testing.
And so, I'm sorry, and this will be my last bit. So you can put COVID on a death certificate or coronavirus even if you don't have a positive test. I just am a little fuzzy about that. Sorry.
Yes, it's the cause of death is determined by the person who certifies the death, and so they have the ability to put that on the death certificate.
Okay, thank you.
They're the only, and just to be clear, as we talked about before, they're the only ones that can change the cause of death. So, there was some concern that the department we would have some reason to want to add deaths. So there's a very formal process for that.
Okay, thank you.
Well, thank you, everyone, for joining us. I think that's thinking about our family members, and I think about my mother's 85, and my in-laws, my mother and father-in-law, Lynn and Val, out in Lincoln County, and my wife's grandmother is 100 years old, and her great aunt is 102, and I think all of us that recognize, and we see that this tends to impact those that are older. But I'll tell you what, Minnesotans are pretty hardy stock, and the story that many of you saw of Vera Mueller down in Winona, Vera was the oldest person in the United States to survive COVID. She's 104, and she whipped it. And as she said, she's lived through the first flu pandemic of 1918, World War I, the Great Depression, World War II, and now she beat COVID-19. So it's Vera's perseverance, and I think that attitude that we are on the upswing on this thing. We're learning more every day. We've come together as a state, both using the innovation and intelligence and our incredible health care, but also a sense of community and neighborliness. So, Vera, thank you for being a role model for all of us. Thank you for proving what perseverance can do, and we look forward to that 105th birthday. So thank you all, and we'll speak more tomorrow.
Find more local news stories at ccxmedia.org and follow us on social media.